Welcome to UOA On Demand. I'm Dr. David Polonet from University Orthopedic Associates. Today we have three orthopedic trauma specialists together to talk about malunions. It's a challenge that we encounter pretty frequently in orthopedic trauma surgery and other areas of orthopedic surgery. We can see this type of problem. I'm going to start with a pretty simple question in a Q&A type dialogue where I'm asking to Dr. Carlos Sagebien, and we also have Dr. Sergei Pushilin. But Dr. Carlos Sagebien, welcome. I'd like to know, what is a malunion? Is this the same thing as a deformity?
So it's similar to a deformity. A malunion, in the most simplest form, is basically a bone that is not healed normally after a fracture. So by implying a malunion, you're implying that there was a fracture, the bone was broken, it went on to heal in an abnormal position. Deformity is similar. Your bones can be deformed, but the deformity could be secondary to a birth defect. It could be secondary to an injury to a growth plate that led to someone's bone growing in an abnormal position. And the end result can be very similar, however, and they can be treated very similarly. So the bottom line is that a malunion is a bone that has healed, but is healed in an abnormal position. So you can think about bones that either look bent, so it looks like someone's got a very crooked leg or a crooked arm, and that could be in what we call the frontal plane, where you're looking at someone and you could see that the bone just is going either left or right compared to the patient's anatomy. You could be a deformity in what's called the sagittal plane, so you're looking at the side of someone, and it looks like the bone is either bent going too far anterior or in front of the person, or the bone can be bent posterior or behind the person. That's a sagittal plane deformity. And finally, you can also have more subtle deformities, which are rotational deformities. So a bone can heal perfectly straight, but it may be rotated so that someone is forced to walk with their toes pointed out or their toes be pointed in. And that could be very disabling for a person as well. So that's very important. And finally, a bone can heal too short or too long is sort of the final deformity. So bones could be bent in multiple planes, they could be mal-rotated, and they could heal short or long.
Okay, is there a difference, Carlos, when we talk about pediatric injuries, like if a bone is still growing versus if a bone is fully grown in an adult?
Well, I think that is an important point to raise, that as you're growing, your bone can be somewhat deformed and it can heal in an abnormal position. But the benefit of being a pediatric patient, especially the very younger pediatric patients, is as they grow, their limbs do have the amazing capability of straightening themselves out. And although parents may feel uneasy about it, with enough time, generally within a year, that bone will look perfectly straight. So it's definitely a different world between the pediatric deformity and an adult deformity.
Okay, thank you. Serge, Dr. Pushilin, what causes a malunion? Are there different types of causes of this type of problem?
Well, typically, when we refer to malunion, is a bone that healed in an incorrect or an abnormal position. We usually refer to that as a result of a trauma or as a result of a broken bone, and that can be either because of surgery or if something was treated without surgery. Sometimes, in rare cases, a injury can be missed by both the patient and sometimes other physicians, and the bone will go on to heal, but there will be later found that there is a malunion. But either case can produce a malunion, whether it's we fix things with rods and plates, and the bone can shift after the surgery and still heal in an abnormal position. Sometimes the devices that we use can fail, and the bone will go on to be bent or shortened, and it'll still heal with time in an abnormal position. But the same thing can happen in a cast. If you put, for example, a broken wrist in a cast, which is very common, it can slowly shift into a unfavorable position where you can notice clinical problems down the road. So even though it healed, you lose a certain amount of function, and it's a malunion in that case. And different, depending on the bone and the location, malunions have different criteria that we go off of to determine whether the malunion will cause a problem down the road, or how significant it will be.
So sometimes the malunion can be a cosmetic deformity that you can look at. Sometimes a malunion might be a loss of range of motion of a joint, and it can also result in potential pain, I imagine. So, these are different challenges that we can see with a malunion. I guess another question that you've alluded to is that it can happen after surgery. So, Carlos, I guess a question that I would have would be, why would this happen after surgery? And Serge made a comment about things can shift a little bit, but if the solution to a misaligned fracture might be a surgical correction, why wouldn't the surgery in the first place be preventing that problem?
Sure. So there's obviously a lot of factors during any surgery. There we would consider patient factors, and there we consider hardware factors, where you're going to use to fix the bone, and finally imaging issues and more technical issues in the operating room. So there are certainly times when everything goes great in surgery and the bone is perfectly aligned, but there can be some patient factors. You can have patients that smoke, patients that are diabetic. These are things that prolong the healing time, and as things take longer and longer to heal, it is likely that sometimes the fixation can get a little loose, and as it's healing, you even see some hardware, some screws back up. You can see things break, but if lucky or unlucky, any way you want to look at it, it can happen so slowly that the bone, as it's healing, is also deforming, and eventually the bone wins the race. It does heal, but unfortunately it has healed in an abnormal position because there was some loss of fixation, and things slowly got crooked. You can see that for certainly in cast treatment. When you put someone in a cast for a fracture, that you've got less control of the bone, and it can slowly deform, and it happens very subtly over time. But all of a sudden, when it's finally healed, you realize that it's a little bit more abnormally aligned than you would like it. So that's certainly an issue. Other issues are in the actual operating room. Yeah, our goal is always to make things perfect, but sometimes, given the complexity of the fracture, it sometimes would be okay to accept a little bit of deformity if you know it's going to really increase the chance of the bone healing. So I think a good example is if you do fractures on someone's humerus. Luckily we don't walk on our arms, and if the fracture, for whatever reason, would be much better aligned, slightly in an abnormal position or shortened because there was bone missing from an open fracture, you're certainly willing to take a little bit of malalignment to increase the chance that the bone is going to heal. And so I think those are all things that can certainly happen. Our goal obviously is always to make surgery perfect and to make limbs perfect, which is going to increase the chance of you having a successful outcome long term. But certainly things can happen.
Right. So if bones don't always line up perfectly, I think sometimes the answer is there's something that legitimately is known as good enough alignment that's not perfect, because perfect is always the goal. Sometimes if there's a couple of degrees of angulation or a couple of millimeters of shortening, that's not going to result in a clinical problem for a patient. Certainly on the small scale of things, if there's an arm that's a couple of millimeters shorter than the other arm, you would never know. So I think it's important to understand that the site of the injury makes a big difference. And then there are certain factors that can sort of compensate for imperfect alignment, where a surgeon might, such as we might look at an X-ray and say, well, it's not perfect, but as a patient, you're not going to know the difference between this and absolutely perfect. And so let this heal and you'll be happy with the result. And we have to use our judgment in terms of making that determination in our experience. Some injuries will not tolerate much of a misalignment or a lack of perfect alignment. A few degrees of imperfect alignment in the tibia or the shin bone can result in a significant offset of the position of the foot when people are walking, and that can result in an outcome that isn't what people are going to be happy with. Whereas in the arm or the humerus, as Carlos mentioned, there's a lot of motion in the shoulder that can compensate for an imperfect position of an arm, and we don't walk on our arms. So a patient may have a few degrees of imperfection of the alignment of an arm, and they have no sense that there's anything off from perfectly normal. So that's important conceptually.
Those are all great points, Dave. And I think that kind of just makes me think of the fact that not every patient is the same either. We really do treat patients on a case-by-case basis. And professional baseball player, they may need a perfect humerus, but my mom broke her arm. I'd let it heal 20 degrees crooked and she'd be perfectly fine. She's not a high-level athlete, so it's really important. And I think we're very good at doing this, of treating patients on a case-by-case basis.
Serge, how would a patient know if they had a malunion, if they had an outcome that wasn't acceptable or adequate?
Well, there are some obvious cases where patients will be treated in a cast, for example, and they come out of the cast, and the first thing sometimes you notice is an obvious crooked deformity. That cosmetically is usually the first thing. The first thing you see is what you notice. There are more subtle ways that patients may notice their function changes. Even though cosmetically you might not notice it, or you feel that there's just a slight change in how your arm or your leg or your foot or your wrist may look. And if everything works to your satisfaction, then it's almost doesn't matter, because you get what you want out of your limbs and your life with this. But sometimes a smaller malunion can lead to a more noticeable functional deformity, where things become more difficult to do. You're unable to do things you were previously able to do, and then the patient would notice that this is concerning to them, and that's when they'll seek out an opinion typically. But in the same, but we also, I'm sure, have seen patients who, when you see them clinically, you right away, as an orthopedic trauma surgeon or any orthopedic surgeon, can say, oh, that looks odd, there's something different about that patient, but they have no complaints because they're fully functional. So the cosmetically is the first way you notice it, and to some people, if it's a very noticeable cosmetic difference, we take that into account. We don't just brush it off and say, oh, it just looks funny, go live with it. For some patients, it's very important, but that's something we will discuss with those patients. It's more concerning to us when it affects their function or causes them pain. That's when oftentimes we would have to evaluate what the issue is, where the issue is, and is it correctable, and how we can correct it. And that's how we then go on from there. But again, just like Carlos mentioned before, you go very much case by case basis with these patients, and listen to what they say and what's bothering them, because in the end, only the patient self knows what's bothering them, how they feel about this. It doesn't matter what the x-ray shows, but if the patient's having pain or is clearly having his or her life affected by this deformity, then it's something we have to take seriously.
You ever get into a circumstance where you see a patient who has an x-ray, they don't perceive a deformity by looking at their arm or their leg, but you look at an x-ray and you say, this may not be causing you a problem today, but this is going to be a problem in the long run, and we need to correct this surgically. Is that a surgeon determined problem ever? You ever see that?
Yes, of course. And this can come up down the road and in the future, is the combination of a little bit of deformity, a little bit of dysfunction, a little bit of abnormal motion may not be necessarily painful or inhibitive of someone's life, but as time goes on, all of that adds up, and you know that as surgeons, that in the future they might go on to arthritis, or they'll not, whatever, let's say they injured the ankle, that may affect their knee, that may affect their hip, that may affect their spine. It's not very common after injuries, at least I see it pretty often. I'm sure you see this as well. People who had lower back pain that they had at some point throughout their life, but it was manageable. Then they go through an injury. They have the injury affects other parts of their body, and all of a sudden that back pain comes roaring back, and it becomes an issue. And that's not necessarily because of the back itself, but let's say they went on to a malunion or there's something functionally abnormal that causes them those other things. So everything's connected. It can all affect the body either immediately once the bone heals, or add on, and later in life they'll have issues. So we oftentimes will take care of that as well, and oftentimes see patients who are concerned with what the future will hold for them.
Yeah, I think that's the easiest example of that I can imagine is like when someone's one leg is shorter than the other leg, and it throws them off kilter, and they're not walking straight anymore, and it basically throws everything out of alignment. And in this case, we can see that if it doesn't hurt you today, this is going to hurt you next year, or the year after that, or maybe in 5 years. But that, there's opportunities that we can identify to give people long-term outcomes that are worth the intervention that we're going to provide. And so, Carlos, what is the treatment of a malunion? How can we solve these problems? How do we solve these problems?
So I think it's a combination of things. One that we've alluded to already is that the first step is to talk to the patient always on a case-by-case basis. Look at the patient, ask them what they want, ask them what is upsetting them. Is it mainly cosmetic? Is it mainly functional? And that's to start the dialogue. Once you've decided that you want to go ahead and proceed with treating the deformed bone, then there are multiple options. And again, although it's less likely for a malunion as opposed to a non-union, which is a bone that's not healed, you really need to look at the patient and see if there's factors that you can fix before surgery. The most obvious ones are obviously smoking and diabetes. There's other nutritional things we look at, calcium levels, vitamin D levels, things that may have contributed to the malunion. You really want to correct those things before you proceed with the surgery. The second step is always to make sure that the patient has buy-in. The patient needs to know that going from a bone that's crooked but healed to one that is now straight but not healed has another host of problems. Anytime you revise a healed bone, there's a risk that it's not going to heal. So those are all discussions you have to have prior to surgery. And there's risks and benefits to the procedure. We'll, I'm sure, discuss that later. So in the most basic form, fixing a deformed bone means you need to unfortunately break it again. And that's what's called an osteotomy. And we've got different devices to do that. There's bone chisels, there's saws, different ways to refracture a bone. Once you refracture the bone, you can then straighten the bone. You can fix the rotation, you can fix the crookedness, whether it's in the frontal plane, like I said before, the sagittal plane, and then you need to fix it in a straight fashion. And then there's three main ways to do that. And one would be what's called a plate and screws, which generally go on the outside of the bone, and that's a way of fixing a broken bone. The second way would be what's called an intramedullary device. So bones are long bones, the humerus bone, the femur bone, the tibia bone, are hollow on the inside pretty much. So we can put a titanium rod down the middle of the bone, and that helps make it straight and helps fix it. And finally, there's something called an external fixator, which can be a very powerful tool. It's a little bit more cumbersome for the patient and really needs to be discussed thoroughly with the patient prior to surgery. But that is a very powerful tool that can slowly straighten a bone rather than doing it all at once. And there's different reasons for that that we can discuss later. But those are the three main options. And so again, these are big surgeries and really take a lot of patient discussions, and optimizing the outcomes is really paramount to a good, successful outcome.
Okay. And joint replacement might sometimes be a way that we can achieve correction of a deformity as well. Is that not true?
Excellent point. So certainly, malunion can happen just about anywhere. So unfortunately, there are malunions that affect the joint. It can affect your knee joint, your shoulder joint, can affect your elbow joint, can affect your ankle. And so I think that's certainly a benefit of dealing with a subspecialty group like we have at University of Orthopedics. And we've got specialists that do knee surgeries, specialists that do hip replacements, specialists that do upper extremity, shoulders, elbows replacements, and even ankle replacements. So sometimes, depending on the age of the patient, the function of the patient, sometimes a replacement surgery is definitely the best outcome.
Can an upper extremity specialist treat a malunion just by doing the deformity correction that we were talking about, or does it have to be an orthopedic trauma specialist?
I think there are some upper extremity surgeons that are very good at it, and I think again, that's a sort of a little bit of a patient-doctor relationship, and someone you're comfortable with, someone that does a lot of the surgeries. there's certainly some very, very good upper extremity surgeons in our practice that can handle non-union surgeries just as well as anybody. I think on average, the three of us probably deal with that a lot more than anyone else. And I think it's sometimes a very good idea to talk to the surgeon, make sure they do a lot of it like we do. And the experience, as you know, the more gray hair you have and the longer you've done this, the more tricks you know, and the more likely you are to have a successful outcome.
I think you're suggesting that I should have a lot of tricks at this point in time. That's
Correct.
that should be true. Also, I'd like to show a malunion case if we can show some pictures. I'm presenting basically the case of a 53-year-old male who was a pedestrian walking when he was struck by an automobile. He had a complex injury of his tibia and the associated fibula. So there's the shin bone and the second smaller bone in the lower leg. And the first image is of a CAT scan or a CT scan that shows a very bowed, angulated injury. This was, as Carlos mentioned, we look at things in different planes, like the X, Y, Z planes on a grid. This had a two-plane deformity, so it was bent, not in one pure plane, but in two different planes. As many of these deformities tend to be, they're not simple. The initial deformity was about 40 degrees of an angulation of the tibia. And so it was very, very visibly noticeable and very painful for him walking. He had a hard time putting his foot in the right place because of the offset of the foot relative to where the knee was. And so he was referred to see me after cast treatment resulted in unacceptable alignment. And he required surgery where I did an osteotomy or a cutting of the bone in multiple places so I could straighten out the leg. And then I treated it with an intramedullary nail, which you see in the subsequent pictures. You see a front and a side view of the intramedullary nail. This went on to heal and the hardware was removed, and you can see the alignment of the bone. Now this is a straight bone where previously we had a significant deformity of the bone. So that's an example of treatment of a malunion. And we have multiple cases that we have each done in the various different bones of the body that we treat, and where we could all show different cases similar to this, but the goal is to give somebody a result and an outcome that's satisfactory to them. Carlos, you did mention that the surgery does have some risk, and you mentioned different problems that we can see. Obviously, this requires anesthesia. Generally speaking, I would imagine this is a general anesthesia, not a spinal anesthesia or a local anesthesia. This is a significant operation. Serge, can you tell us about what the risks are of having deformity correction or malunion correction surgery?
Yeah, of course. You alluded to a little bit of the first factor. This is, once you spoke to the patient, discussed the options, you go on to surgery. And this is just like many other surgeries, you need an anesthesia for this. And again, you also alluded to the fact that as you can imagine, if you have a deformity of any bone where you, especially let's say if after having a previous surgery, sometimes you have to spend time taking out the hardware. You need to make new cuts in the bone to realign it, put in new hardware. So these are not the short procedures typically, and they require time. So you are required to be under anesthesia for a period of time. So of course, before any surgical procedure, no matter how young you are, how old you are, we evaluate the patient carefully, make sure they're in good health, that any factor that we can make better before the surgery, we would. We work with our anesthesia team, our primary care and specialized physicians as well to make sure the patient is ready to go. But all of those things have to be considered. Just because you decided or need surgery, next step is not next day go to the operating room. You have to factor all of these patient factors into it. And because you are operating on a bone, you're essentially taking a bone that's healed in a abnormal position, and you're redirecting it, you're sometimes cutting it again, repositioning it. You're risking that this bone, because it had to heal one time before and you're forcing it to heal again, it may go on to a non-union. again, we try during the surgeries, we do try to optimize those factors, and this is where kind of the trauma surgeon experience comes in, how to make the best out of this situation. We always worry about infection with any surgery, and especially with longer, bigger surgeries, we always keep an eye on this, and we take the patient factors into account. If the malunion occurred because of an infection in the past, that's always a concern in our mind to make sure there's no infection. And we do that both before and during the surgery to confirm this, so it doesn't result in another poor outcome. In cases where someone lived with a deformity for many years in an abnormal position, sometimes correcting the deformity can cause problems with the soft tissue around the bone. The muscle gets stretched, the ligaments get stretched, the nerves and the blood vessels around the bone can be stretched, and that's something important that we take into account, which a lot of times can make us choose a slower correction versus an acute correction. These are these specific things I discussed are factors with malunion surgery specifically. So it's a lot of information, and all of this typically we discuss with the patient to know what they're embarking on, and we'll be there to help them with that as well.
So as Serge was saying, that this is very, very detailed surgery when it comes down to the surgery itself, and also the planning that goes into the surgery is extremely detailed, so that geometrically we get things that are aligned. If you came to us for a deformity or a malunion and we corrected it and didn't get it quite straight, you might be disappointed that you put all this effort into as a patient going through this much surgery. And so obviously a tremendous amount of planning goes into the surgery, even more than a lot of the planning that goes into what the surgery when somebody comes in for a fracture in the first place. So we have the benefit of time to plan for the surgery, but also we have the obligation to get it really right at this point in time. So a lot of planning goes into this. Carlos, how can somebody contact us for an opinion or for care if they think they have a deformity, or if we're told that they have a malunion?
So all three of us are always very welcome to give anybody an opinion, and they can contact us at any time. We ask them to please go to uoanj.com. It's our website for University Orthopedic Associates, and they can schedule an appointment at any time to see one of the three of us or any one of our other subspecialties subspecialists that can help out with this type of fracture surgery.
Okay, thanks very much. Thanks, Serge, and thanks, Carlos. I will point out that that Serge did mention that non-union, or a bone that doesn't heal, is a potential complication or problem. And we do have another UOA on demand where we discussed the topic of non-union. So feel free to look that up on our website as well. And this concludes our UOA on demand for this evening. Thanks very much.
Thank
you,
you.
David.